Welcome, friends of the Retina Channel Podcast, to another episode of this series. Today, I'm very pleased to be joined by Dr. Jennifer Sun, one of the world's leading experts in diabetic retina disease and one of the major leaders within the DRCR Retina Network. Dr. Sun has been on this podcast before, twice, but many years ago, and I'm very pleased that she accepted my invitation to come back to Retina Channel Podcast. She's a professor of ophthalmology at Harvard Medical School, Chief of Center of Clinical Eye Research and Trials at the Beetham Eye Institute of the Joslin Diabetes Center, and the co-chair of the DRCR Retina Network. Over the past decade, she has helped lead and shape many of the landmark clinical trials that have transformed the management of diabetic retina disease. Her work spans clinical trials, advanced retinal imaging, biomarker discovery in diabetic retinal disease, and she has published extensively in many of the world's leading medical journals. In this episode, we'll be discussing phase 2 results from DRCR Retina Protocol AN, evaluating Tonabersat for diabetic macular edema. And what makes this mechanism interesting is that these findings are not the traditional VEGF pathway. It's a different pathway for potentially addressing diabetic macular edema. Well, without further ado, this is Dr. Sun. Thank you so much, Dr. San, Jenny, for accepting my invitation. Welcome back to Retina Channel Podcast.
Thank you so much.
Yeah,
Really
it's
good
been
to
a
see
few
you.
years since I had you over here, so eager to learn more from you again and talk about the DRCR protocol AN.
Yeah, excited about discussing it.
Perfect, perfect. Well, just for the listeners and viewers, the episodes are now also on YouTube, by the way. So we have viewers now as well since last time you were here. So
Oh, exciting.
this is multidimensional now. We do you did this protocol AN Tonabersat study. It was a phase 2 study, fairly small as it goes for a phase 2, and 6 month study of I think 139 or not a big number, or 129 adults
129?
with diabetes who had DME but good vision. So essentially protocol V patients. And then
Yeah, pretty much. We took 2032 or better, but the goal was basically to take folks that we did not think needed immediate anti-VEGF. So we accepted patients with good vision despite center-involved DME.
perfect. And then you looked at oral tonabercept.
Yeah,
See if DME gets better. This was an anatomical primary outcome. It wasn't a visual outcome, obviously, because the vision was by definition good. Um, and then the results, I think, were quite interesting for a phase 2 study. I mean, there are some signals in there that I think worthwhile exploring, maybe. So I will discuss that if that's okay with you.
Oh, perfect. Sounds great.
Perfect. So, Jenny, tell us why tonabersat? How did you find this molecule? What's the background for it?
Yeah.
Where else is it used? So give us some background about it, please.
Sure. So it was an intriguing potential therapeutic for DRCR because it is orally available. It's dosed once daily. The dose that we looked at was 80 milligrams, which is 2 pills. I think one of the things that was very attractive to us was the fact that it targets these connexin 43 hemichannels that are overexpressed in diabetic retinopathy. And they're part of the inflammasome, the NLRP3 pathway. And when you block these hemichannels, it reduces the activation and recycling of these pro-inflammatory cytokines. So we know, of course, that there's an inflammatory component to diabetic macular edema, as there is to probably late stage diabetic retinopathy in general. And so to have a VEGF independent pathway that was targeted was certainly interesting. I think the other thing that made DRCR willing to bring this into a phase 2 study was the fact that we had a good track record of safety. So Tonabersat had been investigated and given to over 1,500 participants in prior phase 1 and 2B studies. And these were studies that were evaluating Tonabersat for potential migraine treatment. It did not move forward. There was not good efficacy, for migraine treatment, but it was well tolerated, and they didn't see significant safety issues. And we knew that the most common side effects would be things like headache and drowsiness and dizziness. And so it was really attractive to us, again, to do this non-invasive, novel pathway therapeutic and
Mm.
investigate it in an early phase study.
So it was tested for migraine, but was safe, but not really effective for that purpose. But is it commercially available for any other thing?
It's not commercially available at this point. So we were approached. There was a small industry partner that had relicensed Tonabersat and was very interested in looking at it in regard to ocular complications.
Hmm.
And again, we thought there was enough both preclinical data suggestive of potential effect in terms of blocking inflammatory cytokines, including VEGF, and preservation of ERG function in rats with spontaneous hyperglycemia and reduced microaneurysm formation and so forth, that we thought it was worth a try in DME.
Gotcha. And in terms of side effects, you mentioned the dizziness and headaches and all that they found in the migraine study. Um, how is this supposed to be cleared from the body? Is it a liver thing, or is it kidney clearance? Or potentially, if you're looking for any potential side effect, would that be in kidneys? Would that be in liver, or no side
Yeah.
effect at all? Because it's a very simple molecule to get cleaned up in the body.
Right. And it's a good question. And we actually looked at both liver enzymes and kidney function as part of the study.
Hmm.
Um, and maybe happy to sort of delve into those a little bit more. We did not see signals in terms of liver function, changes as we looked at AST and ALT. The data was reassuring, and they hadn't seen previous signals either. Now, the renal adverse events were interesting because part of our pre-specified adverse events were looking at the percentage of patients that met certain thresholds of renal function. So in patients with baseline estimated GFR greater than 60, what percentage met a threshold of less than 60 at any point during the study and at study end? What percentage met thresholds of eGFR less than 30? And we actually saw higher rates of Tonabersat treated patients that met these thresholds, that we usually think of as clinically significant or relevant. So, for example, 23% of Tonabersat treated patients had eGFR of less than 60 at any visit through 6 months versus 9% of the placebo treated patients.
Hmm.
But what was really important, I think, to realize is that they were large, unfortunately, baseline imbalances, despite the fact that this was a randomized study.
Hmm.
We did see baseline imbalances with higher rates of renal disease historically, and also lower baseline mean eGFR in the Tonabersat treated eyes. So when we
Hmm.
looked at, just mean change of eGFR, it was very similar between both the Tonabersat and the placebo treated patients.
Got it. Change was the same, but perhaps because of imbalance at the baseline eGFR, Tonabersat patients showed kind of worse eGFR towards the end, but they started off worse as well. Okay,
Yeah.
perfect. So let's focus on the study results. So you had these patients with DME, fairly good vision, and then you gave them oral Tonabersat once a day, 2 pills, and then you looked at them throughout 6 months. And what were the results? You're looking at the OCT outcome essentially. What did you find out?
So just as you said, we treated them for 6 months. We followed them. We actually did, after 6 months, they went off study drug, but we did do a follow-up 12-month visit that we haven't reported out yet. The FDA did ask us to include that as part of the study, just as another safety assessment. And so that, will be forthcoming, I think, in the future. But
Mhm.
through 6 months, what we saw was, trend-wise, there was a trend for Tonabersat treated eyes to have reductions in thickening compared to the placebo treated eyes, which pretty much sat right around where they were at baseline. Now, in the primary analysis that was pre-specified, that didn't meet statistical significance. The p-value was 0.08. There was, an adjusted mean difference of about 16 microns, so not a big difference between the groups. We used a sort of last observation carried forward approach for the patients that got anti-VEGF for diabetic macular edema.
Hmm.
What we realized in hindsight, which is always 2020, was that we probably should have, as our primary outcome, used a pre-specified analysis that used LOCF for any eye that got anti-VEGF for any indication. And in fact, and so we did that as a post hoc analysis. There, we did have a p-value of 0.02 when we took out any indication. And what it did was it took out two eyes in the placebo group, one of which I think had a change in OCT central subfield thickness with anti-VEGF of something like 200 microns improvement. So it was a
Hmm.
big difference just with that one eye. And
Hmm.
it
And
had
this was in
statistical
what group?
balance
This
in the
I
placebo group.
in the
In
placebo
the
group.
placebo group.
So
So,
they got to get
the
boost that
eye,
way in
it got,
the.
right. So the eye, the investigator was treating the eye for the primary indication, they said, of DR rather than DME, but it
Oh,
was
okay.
clear that there was a dramatic difference, in
I
central
see.
subfield.
I see. Okay. So obviously, as you mentioned, they had or allowed rescue treatment for DME if the vision got affected, and some got it. So just to summarize it, so when you did the primary analysis, even though I looked at the graph, it was clear improvement in
Yeah,
Tonabersat group from the all every time point there, but they were just the bars just crossed over. Um,
that's
uh,
right.
but then when you took out patients who were lost to follow-up because of treatment of DME or just and then the results is actually statistically significant, although this was a sort of post hoc analysis. This wasn't pre-specified.
Right. Lost to follow-up. I mean, what happened was in the primary analysis, we took out anybody who was treated for the indication of DME.
Hmm.
But there were patients that got anti-VEGF for other indications, mostly diabetic retinopathy. So, for example, PDR, perhaps. And
Right.
when we took out those patients, because we said, well, of course the anti-VEGF could have an effect, then it met statistical significance.
Okay.
So,
So that's promising. That tells us if perhaps if bigger study or these are pre-specified, etonabrasab could at least be complementary to anti-VEGF for DME.
yeah, I mean, I think in these phase two studies, the way I always look at them is it's nice to have a p-value. What you're really looking for is potentially consistency of effect across analyses because
Hmm.
the phase two study is never going to be a definitive outcome. And so what you really want to say is there enough data here that's suggestive of a biologic effect that you might want to move on to a phase three study? And this
Hmm.
was a beautiful example of a study which was not a home run in terms of primary outcome.
Hmm.
And that's important to know. I do think there were a number of sort of secondary and exploratory analyses that, trend wise were consistent with a potential biologic effect in ways I think that are encouraging. So
Hmm.
another analysis we did, which, was a pre-specified secondary analysis, was we said, well, is there an interaction with the baseline central subfield thickness and the treatment effect? And in fact, just as in protocol T, where we saw with good vision, eyes responded very similarly to the three VEGF agents, anti-VEGF agents, but with worse vision, there were dramatic differences in treatment effect.
Hmm.
Here, we saw with only mild thickening, eyes that were thickened less than 75 microns above our pre-specified thresholds for center-involved
Hmm.
DME.
Which was like 310 or something, based the standard DRCR thresholds,
Yeah.
right? Based on the
Standard DRCR
OCT.
threshold. So,
Yeah.
usually for spectralis, 305 in women and 320 in men. So if they were less than 75 microns above that, there wasn't, there was really no identifiable difference between the treatment groups.
Hmm.
But in eyes with thicker retinas, 75 microns or worse, than the thresholds, um, then there was good separation of the curves. And the p-value for that interaction, again, was significant, I think at 0.02.
That was significant. This was secondary outcome, but pre-specified. So that
Yes,
is
yes.
critical. Although I imagine the numbers have been small in this subset
The
of more
numbers
than
were
because
small. And one of
yeah.
the things that, again, there are always things you wish you had done perhaps differently when you look back. So when we started this study, our goal, based on the kinds of eyes that we had enrolled in Protocol V, was to get three subgroups of eyes. Eyes that were less than 75 microns above the center involved DME thresholds, eyes that were 75 to 125 microns above the threshold, and eyes that were more than 125 microns above the threshold.
It's
Three
very hard
subgroups.
to get with good vision.
Well, that we found, and what happened was we had a very hard time recruiting those thicker eyes
Yeah.
to the point where ultimately we said, you know what, we're going to, we can't keep the study going forever, and so we ended up ultimately with we collapsed the upper two groups, and we only enrolled a third of the eyes in what would have been, what should have been two-thirds of our group. So
Yeah,
so the numbers in the highest, thickest eyes were quite small,
I
and
see.
that's where we saw the effect. And I think this is where kind of the interest lies, perhaps, if there's a follow-up study to be done. I would love to see it done in, eyes that are thicker with perhaps more severe disease, and possibly in eyes with vision that's not just 20/32 or better, but
Yeah,
open to eyes with worse vision.
like obviously I'm nowhere in the planning committee, so but maybe
Oh,
eyes who get treatment and compare them with anti-VEGF Tonabersat with anti-VEGF only. Uh,
well, that would be interesting. I mean, but I think, yeah, we would need to look at the sample sizes that need to be involved, because anti-VEGF has such a strong effect, right? We know
yeah,
many eyes respond really pretty well.
pretty well,
So
yeah.
yeah. So I think the role for this oral medication is really, does it have enough of an effect that it might let you hold off on injections, or in some eyes avoid injections down the road,
Yeah,
or or
yeah,
potentially, as you say, reduce the number of injections.
yeah,
Like,
exactly. Yeah, that's fantastic. So is it fair to say it kind of is acting like a steroid if it's anti-inflammatory in nature, potentially could be like a steroid-like effect?
yeah, that's an interesting question. I mean, yeah, it is. I mean, inflammasome certainly looks at sort of chronic inflammation, and it's particularly interesting, I think, in the context of some of the recent data that's out in terms of IL-6 inhibition and anti-inflammatory nature of that, perhaps. It'll be interesting down the road to understand how these different targeted pathways, do or don't have additive effects to what we get with anti-VEGF.
That's wonderful. So the big question is are you folks going ahead with phase three?
Well, I would say that I think this is not ready for a phase 3 trial at this point.
Okay.
I think the hesitation is always, you don't want to overinterpret your data and
Hmm.
jump to a phase 3 trial that's going to require a lot more resources, and a much longer duration. But I do think there was enough of a signal here that I personally would love to see a follow-up focused phase 2 trial, again, in eyes with, more severe disease. And I think given what we've seen here, I'd be pretty comfortable enrolling patients, um, and saying, as long as I can rescue them within a few months, we could potentially do a very short, focused, 6-month study. Again, looking at, does this
Oh,
have a
like a
role?
Tonabersat versus anti-VEGF type of idea.
Yeah, or even
Yeah.
Tonabersat again versus observation, just to see, can we hold
Mhm.
off the need for anti-VEGF? Are enough eyes responsive that we could give patients the alternative of an oral pill instead of jumping straight to injections?
Hmm. I guess maybe another question would be in your follow-up and the pictures and in terms of DRSS level, did you see
Mm.
any change in that with Tonabersat? Did it make any difference in that with that
Yeah,
device?
so we didn't, I there wasn't, and we didn't really expect a change in DRSS, and as you mentioned before, we didn't expect a change in visual acuity,
Mhm.
and of course, we didn't see a change in visual acuity in these eyes that all started with good vision that
Mhm.
would have a ceiling there.
Wonderful.
Yeah.
Well, this is great. Thank you, Dr. Sun. This was
Well,
a very informative study. It tells you there are more pathways we're looking at, and that could be explored. It's not just injections as we do in our clinics day in day out. Maybe
yeah.
there are other things to come easier for patients. And thank you so much for leading the DRCR Retina networks.
Oh,
You've been a leader for many years, so I appreciate that. I love DRCR, happy to be part of it and happy to really learn from you folks all the time.
oh, well, you're very kind, and thank you for being interested and in the discussion, which is great. We're always just excited about potential new tools in our armamentarium. So
Yeah,
thanks for,
yeah.
for the
Okay,
discussion.
fantastic. Very nice. And I'm sure I'll see you soon.
Sounds good.
Take
Thanks so
care.
much.
Thank you. Well, folks, this wraps up episode 96 of the Retina Channel Podcast. Thank you for joining us for this episode. And I want to thank again Dr. Sun for her wonderful discussion and taking this endeavor on evaluating Tonabersat uh, for diabetic macular edema. Of course, she's accompanied by many wonderful researchers and coordinators within the DRCR Retina Network, and I'm always thankful to them and appreciate their efforts and wonderful work they continuously have been doing for the past few decades now in new discoveries and giving us the treatments that we so much need for our patients. And if you enjoyed this episode, please subscribe to Retina Channel Podcast if you haven't already on your favorite podcast platforms. And also follow us on YouTube. As you know, these episodes are also published on YouTube. And then make sure you join us for the next episode. I'll be hosting Dr. John Kitchens, and then he'll be discussing the rapidly evolving role of artificial intelligence in ophthalmology and retina practice. Until then, take care. I'll see you then.